this session is a grab bag of general surgery topics, and it's an honor to introduce our moderators. Dr. Suzanne Yoder is a pediatric surgeon who does locum tenens work and is based in Shell Beach, California. Dr. Diana Deason is associate professor in the Department of Surgery at UT Southwestern Medical Center in Dallas, Texas. And our chat monitor is Dr. Ali Makdad, who is a pediatric surgery fellow, soon to be at Cook in Dallas. Correct? Like, she's currently a fellow at Johns Hopkins All Children's in St. Petersburg, Florida. So thank you.
All right, we're going to jump right in and get going. Our first talk is real-world multi-institutional data from the Midwest Pediatric Surgical Consortium to assess the effect of delayed Kasai procedure on biliary drainage in patients with biliary atresia. This is presented by Dr. Zeeshan Faruqi.
Thank you for the opportunity to present our work. So with biliary atresia, it's well established that early intervention with the Kasai-Porter enterostomy is key to provide biliary drainage. This has been proven time and again in various national and international cohorts. So as we can see with the survival of the native liver on the y-axis here, for patients who got a Kasai at less than 30 days of age, survival with the native liver even 10 years out was about 50 to 60%. And when that time to Kasai goes up to 60 or 90 days, that survival drops down to about 25%. So it's very clear and well known that early treatment is key. However, there's a problem of late referral. There's diagnostic uncertainty, which can lead to unnecessary, sometimes unhelpful testing. There's a lack of standardized, reliable screening and diagnostic markers as well. And so for all these reasons, a shorter time to Kasai has yet to be achieved in the standardized fashion in the US. So to better understand this, we can think about workup and treatment of biliary atresia in a simplified schematic or a process map. Outlined in the purple here is the initial workup, which is the pre-referral phase. This is the phase prior to which patients get a fractionated bilirubin showing direct hyperbilirubinemia. After that, they get referred into the system, after which they go hepatology, surgery consultation, labs imaging, additional workup, and then eventually the Kasai procedure itself. So in order to I'm having a little bit of trouble. So we asked the question here, is there institutional variability in this process? So is there institutional variability in initiation of jaundice workup, which is obtaining that fractionated bilirubin? And is there institutional variability in operative timing of patients? And if there is, how does that affect successful drainage of the Kasai? So we designed a retrospective study at 11 tertiary children's hospitals looking at infants with biliary atresia. We collected important parameters on age at initiation of diagnostic workup, age at the time of the Kasai, along with biochemical parameters post-Kasai. And our specific outcome of interest was direct bilirubin normalization at 3 months following the Kasai, and this is a well-established prognostic marker of survival with the native liver. And so overall, we had 163 patients. Our demographics characteristics were not significantly associated with whether or not a patient got a Kasai at an early age, but what I'd like to direct your attention to here is the age at specific times of the workup. Specifically, the median age at initial labs, as shown on this box and whiskers plot, was 39 days. And there was a broad interquartile range, about 9 to 62 days. As the workup progresses and the patient actually gets the Kasai, the median age at Kasai is about 53 days, again with a broad interquartile range. In data not shown on this box and whiskers plot, the median time from initiation of workup to Kasai was 9 days. And this becomes important because the odds of clearing bilirubin at 3 months postoperatively decrease as time progresses. So for every 10-day increase in age at Kasai, there's about an 18% decreased chance in our data set of achieving biliary drainage. So then we compared various aspects of the workup of biliary atresia across institutions. Applying Muth's median test, we noted that there was a significant difference amongst institutions from the time of initiation of workup to the point where the patient actually received the Kasai. And this is actually shown in, this is signifying this aspect of our process map in our workup. And again, just to emphasize, time is key here. So then our next natural question was, does the clearance of bilirubin itself vary by institution? So we investigated this by performing a logistic regression model, again, with the outcome of interest being postoperative clearance of bilirubin, including institution in the model and controlling for demographic characteristics, as well as the age at which the patients received the Kasai. In our data set, we saw that the odds of clearing bilirubin varied from between 0.04 to 0.89 with, in reference to a reference institution. Of note, that reference institution was chosen based on highest volume as well as highest rate of biliary clearance post-operative month 3. Institutions C and H had a lower sample size, so we were unable to calculate the odds ratio for those. Overall, the aggregate p-value of including institution in the model was 0.042. And so we can summarize our findings with two major points. So in the pre-referral phase, our median age of initial workup was 39 days, which is still later than we would like to be. And then there's also institutional variability in the time of workup to Kasai. So again, that's this green phase here. And then there's also institutional variability in actually achieving successful drainage. So how does this work guide future studies? So from that initial workup phase, we can ask the question, how can we implement proven screening algorithms on a real-world basis? And there has been work done which shows successful screening algorithms, but not applied broadly. And then importantly, do socioeconomic factors affect age at initial workup? And then once we move to the post-referral phase, when the patients are actually getting the workup, can we standardize this post-referral workup amongst institutions to allow for quicker times from workup to Kasai? And then related to that, does the use of standardized markers such as MMP, or validated markers such as MMP7 expedite that diagnostic workup? And so with that, I'd like to thank you on the behalf of the Midwest Pediatric Surgical Consortium. We'll take any questions.
Thank you for your presentation. Yusuf Gohari, Ped Surgery Fellow at the University of Nebraska. So in the UK, they have a centralized model for Kasai procedures. Only 3 cities in the UK that covers the whole of UK and Ireland. Have you looked at your series of case volume? What's the definition of a high case volume per center at your institution?
Yeah, so we do have that data. I can actually kind of just pull up some supplementary slides. So really the natural question is, why do we see this variation? And so we actually did divide our institutions by tertiles of case volume. And we didn't really see an effect, at that level. So we don't have to shortly answer your question, we don't have a specific definition of what a high case volume and a low case volume is, but we do stratify by that and we don't see a difference.
Hi, it's Omid Madadi from Germany, Hanover. It's very interesting. Just from the European perspective, because we have the centralization in the UK, but we have the decentralized system in France with equal results and good outcomes. However, they have like standardized algorithms that each centers agree on. Does the consortium have anything in between that? Because it's like 14 days between the initial blood tests and the surgical exploration. Seems a lot of time passing by.
Absolutely. So I think that's kind of what our, even with the Midwest Pediatric Surgery Consortium, kind of one of our next kind of prospective studies is to see whether or not we can actually standardize the workup. And that part of that standardization includes using validated markers like MMP7 or other types of things. But standardized workup is really kind of the next avenue for future work.
Dr. Faruqi, one final question for you over here. Hello.
Oh, hey, sorry.
Yeah, Bo Lover, Nashville. I really enjoyed this paper and I find it quite provocative. In Nashville, once the baby who has direct hyperbilirubinemia and other features consistent with biliary atresia, once they head to IR liver biopsy, we have a time point of 48 hours as quality control to get them to the OR for intraoperative cholangiogram. So I see here you have really almost 10 days from biopsy to time to Kasai. What was the issue there? Why that delay? Thank you very much for this presentation.
Yeah, this is really kind of the median time. I think with the biopsy, especially, kind of what we're not able to parse out in our data is really kind of the age at, kind of the age at which they initially present. If they present early, for example, that biopsy still might not be as helpful as completely diagnostic. And so kind of the questions around achieving a firm diagnosis still exist despite getting the liver biopsy.
All right, thank you very much. Our next presentation is entitled Comprehensive Fertility Preservation Can Be Offered in a Timely Manner Around Gonatotoxic Therapy in Children, presented by Dr. McElhaney.
Thank you for the opportunity to present. The American Academy of Pediatrics, the American Society of Clinical Oncology, and the American Society for Reproductive Medicine all recommend discussions about fertility-preserving options for patients who are planned to undergo gonatotoxic therapy. Currently, there are 2 surgical options for fertility preservation. These include ovarian tissue cryopreservation and testicular tissue cryopreservation. Additionally, these are the only fertility-preserving options available to patients that have not yet gone through puberty. There are many opportunities for fertility consultation and procedures within the timeline of a patient's diagnosis and treatment. This includes during initial diagnosis and evaluation, after initial rounds of chemotherapy and radiation, or after treatment plans have changed at the time of disease recurrence. Additionally, it is worth noting that fertility procedures can be cohorted with other procedures critical to the patient's overall care and treatment, such as those listed underneath the timeline. There are many perceived barriers to offering patients fertility preservation procedures, including the need to recover after surgery, concerns about wound complications after procedures, and ultimately possible delays in the patient's overall care. In this study, we examined the timeline between referral, consult, procedure, and continued treatment to better characterize the impact of fertility preservation procedures on the timeline of children's overall treatment. So in this study, we conducted a retrospective review of patients who were referred to the Fertility and Hormone Preservation and Restoration Program at Lurie Children's from 2018 to 2022. This included patients who underwent ovarian tissue cryopreservation, testicular tissue cryopreservation, ovarian stimulation and egg retrieval, and sperm banking. We collected information about patient demographics, diagnosis, clinical course, and their respective procedures. In this cohort, we had 105 patients who underwent OTC, with 72 who were prepubertal. Overall, the median age was 6.6 years old. 97 patients underwent TTC, of whom 87 were prepubertal, and the median age was 8.6 years of age. 39 patients underwent ovarian stimulation and egg retrieval at a median age of 17 years, and 124 patients underwent sperm banking at a median age of 16 years. Across all these patients, the majority were diagnosed with a solid tumor, including sarcomas, Wilms tumor, and neuroblastomas. A large proportion of our patients were also diagnosed with a liquid tumor, which included leukemias and lymphomas. Amongst the patients who underwent an OTC or TTC, the median time from referral to consult was 2 days. Additionally, the median time from consult to their fertility procedure was 13 days. 62% of OTC and 64% of TTC had a cohorted procedure at the same time, such as a port placement or bone marrow biopsy. The vast majority of patients went on to continue gonatotoxic therapy. 33% of OTC patients and 34% of TTC patients continued their treatment for their principal diagnosis either the same day as their procedure or the following day. The median length of time from fertility procedure to treatment was 4 days after OTC and 3 days after TTC. Additionally, 58% of OTC and 44% of TTC patients had some form of gonatotoxic therapy prior to their fertility procedure. 11% of OTC patients and 14% of TTC patients had had a recurrence of their disease prior to fertility consultation or procedure, which explained this prior exposure to gonatotoxic therapy. Median time from treatment after their fertility procedure to ongoing treatment was identical in this subgroup of patients. In the cohort of OTC patients, there were 3 adverse events reported. Each had an unplanned readmission related to abdominal pain, nausea, and vomiting. These patients simply required supportive care with IV hydration and antiemetics. Amongst the TTC patients, there was only 1 adverse event reported. This was a superficial surgical site infection, which required 1 week of outpatient antibiotic treatment and no additional intervention on any of these patients, including reoperation or any other invasive procedure. Our ovarian stimulation and egg retrieval and sperm banking patients were also coordinated with our colleagues over at the adult hospital. Their care was coordinated with their primary teams in a timely manner so that they could continue their care as planned by their primary treatment teams. So in conclusion, comprehensive fertility consultation and intervention occurs within the expected timeline of treatment for pediatric patients undergoing gonatotoxic therapy. Thank you.
So I applaud Lori for taking the lead on this kind of work. Everything we do in Phoenix is based on what you're doing at Lori. And it's one thing that we do consider, though, is the cost, ongoing cost for the patient. How do you counsel the families about the cost of the ongoing banking and then also the eventual use of the tissue and what the potential costs and solutions would be for those families?
Yes, ma'am. Thank you for that question. We just have very frank discussions about the costs of these procedures and the ongoing storage of this tissue and eventually the ultimate reimplantation. Presently, we're very fortunate in Illinois that there is a mandate that private insurance covers these procedures. So a lot of times we get the procedure itself covered by insurance, but ongoing storage costs are always a concern. So we're upfront with them about what that cost is and what we expect that cost to be moving forward, and understanding that there will be costs related in the future in terms of reimplantation and utilization of this tissue.
Hey, Lindsay Talbot from St. Jude. Thanks for that talk. I was just wondering, and I haven't seen this data come out yet, but if you're familiar with data on how long are these cryopreserved tissues really yielding good gonatocyte recovery after storage?
Absolutely. There's less data, obviously, in the pediatric population as compared to in the adult population. Presently, the data is that each tissue that is reimplanted lasts about 2 to 5 years. However, each of these this is for ovaries. Each of these specimens does yield several strips of tissue. So I would say on average, somewhere from 5 to 10 strips are available for the patient that they can use sequentially. For TTC, that is still, for the testicular tissue, that is still experimental. So I don't have the data on that just yet.
Thank you very much.
Thank you.
Our next talk is the successful use of an acellular small intestinal submucosal graft in vaginal reconstruction, presented by Dr. Stephen Papastefan.
Neovaginal construction remains a persistent surgical challenge, but if successful, has the potential to significantly improve patient quality of life, confidence, and allow for sexual function. Many strategies exist for vaginal lining replacement, including endogenous tissue transfer techniques such as bowel grafts, peritoneal lining, and buccal mucosal grafts, or exogenous materials such as skin substitutes and tissue substrates. Each approach has its advantages and disadvantages, balancing similarity to endogenous vaginal tissue, donor site and operative morbidity, and complication profile. For our vaginoplasties, we began using the Oasis graft, which is an acellular porcine small intestinal submucosal graft that has extensive prior experience in burn, urethral, and ligamentous reconstruction, to name a few. Acellular grafts have a unique healing profile characterized by vascular ingrowth as the submucosal scaffold degenerates, and the recruitment of circulating and adjacent progenitor cells that are capable of repopulating the graft. The result is that acellular SIS grafts have been shown to allow for an infiltration of tissue similar to what is meant to replace. There are many theoretical advantages and disadvantages to the various techniques available for vaginal reconstruction. For example, while bowel grafts can be are self-lubricating and may not require dilation or postoperative stenting, they can have a malodorous discharge, they require a bowel anastomosis, and have all the potential consequences of abdominal surgery, such as obstruction and the additional complication of prolapse. Buccal mucosal grafts are another promising alternative and have the advantage of tissue similarity and a hidden donor site, but regardless, a donor site is present and the source material can be limited. Small intestinal submucosal grafts do not require a donor site, are readily available, and in theory repopulate the lining with a tissue that's similar to what it's meant to replace. However, they are an exogenous material and the complication profile is not yet known. So our aim was to evaluate the operative and postoperative outcomes of patients undergoing vaginoplasty with SIS grafts. This was a single institution retrospective review of patients between 2018 and 2022, and we had 13 patients undergo vaginoplasty with this technique at our institution. Briefly, to walk you through our operative technique, the procedure begins by identifying native tissue dimples and using them as a guide to initiate the dissection of a space between the bladder and rectum. The canal is then extended using Hagar dilators. The SIS graft is then sized to the canal, coated with an estrogen ointment, and wrapped around the mold. After insertion into the neovaginal canal, the graft is tacked to the apex of the neovagina and the introitus, and the introitus is closed over the mold and a cystourethroplasty is routinely performed. So our cohort consisted of 13 patients, 5 with cloacal anomalies, 4 with isolated vaginal atresia with or without a transverse vaginal septum, 4 with Mayer-Rokitansky-Kuster-Hauser syndrome, and 1 who had a prior vaginectomy from vaginal rhabdomyosarcoma. These repairs were performed in older patients with a median age of 19 years. Median operative time was 171 minutes and EBL was 10 mLs. Patients stayed for a median of 2 days, and for our most recent 5 repairs stayed only 1 day. And they were followed for 9 months, and median dilating length at most recent follow-up was 9 centimeters. So of our cohort, all 13 patients achieved successful engraftment with evidence of reepithelialization of the canal by 4 weeks. 12 out of 13 achieved a dilating length of at least 6 centimeters, which is a previously utilized benchmark for appropriate dilating length. And 12 out of 13 patients were able to have their molds removed by 7 days and progressed to performing self-dilations. Of the 3 patients who attempted sexual intercourse, all 3 were successful and have stopped dilating altogether. However, 2 out of 13 patients did develop postoperative vaginal stenosis at 3 and 7 months, respectively. These patients were dilated and had not had a restenosis at 5 and 16 months. So in conclusion, vaginoplasty using acellular SIS grafts appears to be a safe reconstructive technique with early evidence of durability and good graft apposition. Mold removal at 1 week is feasible, which is a significant improvement from many other techniques that require longer duration mold retention. However, while this technique has very promising success and some advantages, we really do need to compare this against alternate techniques, and this will be the subject of future study. And thank you, and I'm happy to take any questions.
I made a lot of vaginas in my day. And so this is why I love this. I love Lori again for doing more innovative ways of avoiding bowel for vaginas, which everybody knows I think is not what we should do. So I have a couple questions for you. First of all, do they go home with the mold so they don't have to be in the hospital the whole time? And how do you manage that? The second question, do they dilate right away after you take the mold out? And the third question is, do you really think the MRKH kids need this at all? Because I have just stopped doing it in that population. They just have sex with their boyfriends. Most MRKH patients have boyfriends. They seem there's very few non-binary and LGBT MRKH, which is kind of weird. We can study that. But the MRKHers just have sex with their boyfriends and they make a vagina.
Sure. Thanks for those questions. So the first question, yes, they go home with their mold and a Foley catheter that's in place, and that's removed at 7 days. And like I said, in almost all of our patients, we were able to remove that mold. And they do start dilations immediately. So they're instructed in clinic. We have a nurse practitioner who kind of walks them through how to perform dilations. And they begin by doing dilations twice daily, which really goes on for the first year until maybe at that point when they can just start doing daily dilations. And then the second question, which was, MRKH. Yeah, so, I think it depends on the patient. Some patients prefer doing like the Frank technique of just serial dilation, or like you said, if there's other mechanisms by which they can do that, that's okay. But I think it's, patient preference. I don't know that they need it by chance, but some patients have come into our clinic and, through the conversation with Dr. Grabowski and the whole team said, I want a more immediate fix to this. And so this surgery is basically a way of creating that canal for them so that they don't have to, undergo this serial dilation.
Hi, it's Langer from Toronto. These may be basic questions, but when I've used SIS before, it gets replaced with SCAR. So I'm wondering what this neovagina is lined with and how it gets lubricated and why it doesn't just scar down. And the second thing is some kids have the upper vagina present, and you didn't talk about whether you can hook this up to that upper vagina to allow menses and pregnancy.
Yeah, both good questions. I wish I had an answer for the first question. That's something that we've wanted to study, and we haven't done like a cytological analysis of what the tissue looks like. The thought behind using the estrogen ointment is that there are still estrogen-responsive receptors that are present within either the tissue dimple or that area. So there might be some, kind of repopulation of that tissue, but that's all theoretical. So we don't know the answer for that question right now. And then your second question of whether it can be hooked up. So in one of our patients, we did do that, but in all of our other patients, it's just been creation of a canal and lining of the canal.
May I ask one more question, Dr. Deason?
Oh, so sorry.
Yeah, it's okay. Bo Lover, Nashville. Dr. Papastafan, I enjoyed your presentation. I have used silicone-covered retrievable stents that allow the postmenarchal girl to menstruate, and you can leave them in 3 months, however long you want. And I've found on re-endoscopy that it seems native vaginal mucosa has kind of migrated its way. I don't know the biology behind that, but it seems interesting. I haven't biopsied it to prove that it's squamous mucosa, but it sure looks like it grossly. Mm-hmm. So what do you do with the mold? Where does this come from that you only leave it in 7 days? Can the girls menstruate, or are you timing it in some way? Tell me a little bit more about the mold and its obstructive effect.
Yeah, I'm not actually sure. So it's only left in for a 7-day period, so I don't know that we've run into that issue. However, afterwards, like I said, they're just dilating twice daily after. So for the period after, it's just a serial dilation. And what you said about kind of the repopulation, I think that's what's been, it's been noticed, but not actually studied. But it does seem like there might be a repopulation with some squamous mucosa.
Great, thank you. Our next presentation is entitled Neurologic Complications in Pediatric ECMO for Respiratory Failure, Risk Factors and Time to Event Analysis by Dr. Kaylee Collier.
As we all know, extracorporeal life support, or ECLS, is a well-established treatment to support pediatric patients with acute respiratory failure that's refractory to medical management. Patients undergoing ECLS are at a higher risk for neurologic complications, which greatly increase the morbidity and mortality. Reported incidences of acute severe neurologic complications are up to 30%. Previous studies have identified several variables associated with an increased risk for neurologic complications during ECLS, such as cannulation strategy and various patient-related factors. The Extracorporeal Life Support Organization, or ELSO, provides a comprehensive registry of ECMO patient data, and in 2016 began recording the timing of complications during ECLS runs. The purpose of this study was to better understand these risk factors that are present prior to or around the time of cannulation and how they affect the rate of neurologic complications during an ECLS run, with the goal of identifying opportunities to optimize these factors or modify treatment strategies in order to decrease risk. We used ELSO registry data from 2016 to 2021 and included all pediatric patients who underwent ECLS for respiratory failure. Our primary outcome of interest was the presence or absence of a major neurologic complication as defined by the ELSO database, as well as the recorded time to complication. Significant variables identified on univariate analysis were included as covariates in subsequent multivariable analyses, and time to event analysis using Kaplan-Meier curves was performed. There are around 1,600 patients included in the study, 19.6% of which had a major neurologic complication recorded on ECLS. Significant factors found on univariate analysis are shown below. Ultimately, PCO2 and oxygenation index were excluded from subsequent analysis due to collinearity with pH and PO2, and including oxygenation index due to the multiple data points and inconsistent reporting would have significantly decreased the number of patients included in the analysis. The rest of these variables were included in our multivariable analysis, the results of which are shown here. You can see that when correcting for patient and circuit factors, neither mode of support nor cannulation site were statistically significant risk factors, but lower pH, pre-ECLS arrest, and pre-ECLS use of vasoactive agents were all statistically significant risk factors for having a major neurologic complication during an ECLS run. For time to event analysis, Kaplan-Meier curves were created using neurologic complications during ECLS as a surrogate for mortality. Pre-ECLS arrest and pre-ECLS vasoactive use were again statistically significant risk factors for neurologic complications. Additionally, this increased risk appears to be higher around the time of cannulation. This blue line represents around 72 hours on ECLS support, and looking before and after this time point, there appears to be a higher rate of neurologic complications during the first few days on ECLS in patients who arrested or required vasoactive support prior to cannulation. In contrast to the multivariable analysis, mode of ECMO was a statistically significant risk factor in time to event analysis. Again, the rate of neurologic complications appear higher around the time of cannulation. But in contrast to the previous curve shown, this risk seems to persist over time when comparing VA with VV ECMO. In conclusion, lower pH, pre-ECLS arrest, and pre-ECLS vasoactive use are associated with an increased risk for neurologic complications during ECLS, suggesting that severity of illness prior to ECLS initiation is associated with an increased risk of complications during ECLS. Additionally, this risk appears higher around the time of cannulation. Ultimately, prospective data is needed to determine if cannulation prior to hemodynamic instability lowers the rate of neurologic complications during ECLS. We feel, based on this data, that pre-ECMO factors that affect complications during ECMO runs should be taken into consideration when determining timing and candidacy for ECLS support. Thank you. I'm happy to answer any questions.
Thank you for the nice presentation. Pramod Puliganla from Montreal. Could you just give me, for the pre-ECL or pre-ECPR, how many of those patients actually had cooling after cannulation? Was that a standardized, or were you able to get that information?
We did not specifically look at that information, but that is something that would be interesting to look at. Thank you for that comment.
Krista Grant from New York. I have two questions. Why did you exclude patients younger than 28 days? What's the rationale behind that? And did you look at any data for second runs on ECMO?
We did try, thank you for that question. We did pediatric patients, assuming that younger patients would probably be on, more likely to be on VA support with that cannulation strategy, and we wanted to control for the mode of support, which didn't end up being statistically significant. We excluded second runs, and in the time to event analysis, once there was a neurologic complication or their run ended, they were also excluded. But that is an opportunity for future study, for sure. Thank you.
Okay, we have time for one more question.
Hi, Julie Montaguto from Brown University. I'm just wondering how the results of your study would inform potential imaging recommendations that you have.
Thank you. That's definitely a future direction. I think another step before that would be to parse out what kind of neurologic complication is happening around the time of cannulation. We included all major neurologic complications, which includes ischemia, infarction, hemorrhage, or brain death. So looking at which complication, or if there is a complication that is significantly higher around that time, and then if any increased surveillance or change in anticoagulation strategy could help prevent those.
Thank you.
Our next talk is submucosal hydrogel for spring-mediated intestinal lengthening, presented by Dr. Fereshta Salimi Jaze.
Thank you for the opportunity to present our study. Dr. Don is a co-founder for Eclipse Regenesis. The rest of the authors do not have any disclosure. We have proposed the spring-mediated distraction and enterogenesis for intestinal lengthening. External plication has been performed to confine the compressed spring by decreasing the lumen diameter at both ends. Our goal is to develop endoscopic method for a spring implantation to minimize the morbidity associated with the device insertion. endoscopic internal suturing is technically challenging. So in this study, we examined entrapment of a spring within an intestinal segment by submucosal injection of hydrogel, proximal and distal to the compressed spring. I start with a brief summary about the hydrogel itself. Hydrogel is a three-dimensional network of hydrophilic polymers that can hold a large amount of water while maintaining the structure due to the chemical or physical cross-linkage between the individual polymer chains. The hydrogel properties that we saw for the purpose of our study included biocompatibility, biodegradability within the span of 1 to 2 weeks, lack of interaction with the surrounding tissue, and post-injection swelling. 2 hydrogels that met our criteria were chosen. The first one was hyaluronic acid-based hydrogel, which is formed through dynamic covalent chemistry after mixing equal molar amounts of hyaluronic acid modified with hydrazine and hyaluronic acid modified aldehyde. The resulting bond is chemically strong but reversible, resulting in formation of a stiff gel, which is injectable since the bonds can dissociate. The second one was hyaluronone and elastin-like protein hydrogel known as HELP. The HELP gel system is also a dynamic covalently cross-linked polymer network. It is injectable, cell-compatible, and has independently tunable biomechanical and biochemical properties. First, we performed the in vitro study on the harvested pig bowel to determine the appropriate amount and method of injection. 1.5 to 2 cc of hydrogel was sufficient to cause adequate luminal obstruction to hold the spring in place. The specimen was examined under the microscope to localize the hydrogel as well. Subsequently, the animal study was done on 6 juvenile pigs. To mimic the endoscopic injection, we performed the submucosal injection of hydrogel in an open manner. 1.5 cc of hydrogel was injected into the submucosa of the intestine after averting the transected jejunum. Gelatin-encapsulated compressed nitinol spring was placed next to the injection site. The bowel was unfolded over the spring, and another 1.5 cc of hydrogel was injected distally to hold it in place. Non-absorbable sutures were placed on the serosa of the spring and control segments for full-length comparison. End-to-end anastomosis was done to regain the continuity. Pigs were placed on clear liquid diet and euthanized on post-op day 7. Intestinal segments were evaluated for the amount of lengthening between the marking sutures and processed for histologic examination. Although there was some slippage proximally or distally, springs stayed at the injection sites in all pigs. The initial length in the control and spring segments was 2.5 centimeters. Control segments shrunk by 72%, but the spring segments lengthened to 132% in the hyaluronic acid group and 188% in the HELP group. Of note, the HELP hydrogel is longer to degrade and was associated with more lengthening. Histologic adaptation of the lengthened jejunum was similar among the two groups. We noticed an increase in the crypt width and decrease in the crypt density in the spring segments compared to the control, which might be related to the lengthening process. And this observation was consistent with the results of the study done by Jowett group, which demonstrated that mechanical stretch results in epithelial differentiation and formation of new crypts by stem cells upon collapse. In summary, This is the first study toward endoscopic sutureless spring insertion for bowel lengthening, and further experiments are required to optimize the hydrogel properties and insertion methods. Thank you for your attention.
Our next presentation is gastroesophageal reflux and gastrointestinal symptoms after metabolic and bariatric surgery in adolescents, an 8-year follow-up study presented by Dr. Zainuddin.
Thank you for the opportunity to present our work. This study was funded by the NIDDK, and authors don't have any disclosures. Obesity has been on the rise in the pediatric population in the United States, and up to a fifth of the US children have obesity. This predisposes them to many complications and comorbidities. Bariatric surgery has been shown to be superior to lifestyle and medical therapy in treating obesity and its comorbidities, and the most common procedure are Roux-en-Y gastric bypass and vertical sleeve gastrectomy. When comparing the two, we can usually say that gastric bypass is more associated with overall GI symptoms, while vertical sleeve gastrectomy is more associated with gastric reflux. We've previously shown in our 5-year data after surgery that patients after sleeve gastrectomy have higher odds of having reflux symptoms compared to the bypass group. In this study, we aim to look at longer term, up to 8 years. Sorry, this is advancing on its own. We used the teen longitudinal assessment of bariatric surgery, the teen labs study cohort, which included patients from 13 to 19 years of age who were eligible for bariatric surgery, and we recruited them from 5 US institutions. Recruitment happened between 2007 and 2011, and patients were seen at baseline at 6 months and then annually except for year 7. At each visit, patients' demographics, BMI, GI symptoms, and medication use were assessed, among others. Each of the 15 GI symptoms that were in the questionnaire were on a scale from 1 to 7, from no discomfort to very severe discomfort. This was dichotomized to negative or no symptoms if it was between 1 to 3, from none to mild, and if it was moderate to very severe, we counted that as positive. We created a variable called gastroesophageal reflux symptoms based on 2 of the symptoms on this questionnaire that are acid reflux or heartburn. However, this did not account for patients, sorry, this keeps advancing, for patients who are using medications that might be masking their symptoms. So we created a more composite, more encompassing variable that we called gastroesophageal reflux. We evaluated the prevalence in those symptoms between baseline and 8 years. We used descriptive statistics and multivariable regression, and we adjusted for sex, race, and BMI change. At baseline, there were no major demographic differences between the 2 groups. Overall, we had 228 patients. 161 were in the gastric bypass group, and 67 were in the sleeve group. Also, there were no significant differences in baseline GI symptoms between the 2 groups, not even in the reflux group, especially not in the reflux symptoms or reflux overall. When we look at the 8-year prevalence compared to baseline, we notice an increase in abdominal pain, bloating, and constipation, and decreased reporting in hunger pain. All the other symptoms did not demonstrate a statistically significant change, including those reflux symptoms. On our multivariable regression analysis, and this is for our oval OR cohort, we notice increased odds in some of these intestinal symptoms like abdominal pain, bloating, constipation, and nausea, and reflux symptoms. However, if we include medications, we notice a slight decrease in the odds. When we compare sleeve to the bypass, we don't note a significant change in any of the GI symptoms, except much higher odds in gastroesophageal reflux symptoms, but not when we account for medications. Overall, female had higher odds of some of the GI symptoms compared to male, but there were no differences based on race and no to minor differences based on the BMI change. This is a visual representations for those who don't like tables of those similar tables, which show slight increase in those symptoms, and in the box are on the right-hand side is gastroesophageal reflux symptoms. At the bottom, we see how it's been increasing with the sleeve group and kind of return to baseline in the bypass group, while on the left-hand side of the rectangle, we notice that pretty much returned to baseline at 8 years. The study has limitations with small sample size, especially in the sleeve group, and possible recall bias, especially in the subjective symptoms, and only seen once a year. In conclusion, gastrointestinal symptoms are not uncommon after bariatric surgery, such as abdominal pain, bloating, constipation, or reflux. Reflux symptoms remain more common after sleeve. However, when we account for medication use at 8 years, it's pretty similar to baseline, with no significant change between sleeve and the bypass groups. We still advocate for counseling and routine monitoring for pathologic consequences of reflux after sleeve gastrectomy for those symptomatic patients. Thank you.
Jeff Seitz from New York. Thank you for presenting this. Teen Labs certainly sets the standard for observing outcomes of obesity surgery in young individuals. I had two questions. It's a multi-center study, and so it may be difficult to answer. But at the time of surgery, well, first question, was there any preoperative endoscopy performed? And if so, did the findings affect what the decision was as to the surgery? And second, at the time of surgery, was there any exploration of the hiatus in patients undergoing sleeves to see if they needed anything done or judged to need anything done?
Okay. Thank you for the questions. In terms of the first question, actually, we're just talking about this. Not only a handful of the patients actually had endoscopy or actual objective measures of reflux. Most of this data is subjective based on their reporting of their symptoms. But it is a great idea for the future, if possible, to do objective study prospectively to evaluate reflux in those patients. In terms of your second question, I am not sure whether that was done. Most of these surgeries were performed over 8 years ago. And I did not get that data.
Our next talk is comparing pediatric surgeons and palliative care pediatricians' perspectives and practices regarding palliative care in pediatric surgical patients, presented by Dr. Danielle Ellis.
Good morning. I'm going to talk to you about the state of palliative care in pediatric surgical patients and hopefully convince you that it's not only important, but something that we should be actively pursuing. We have no disclosures. So I want you to think about the last interaction you had with a palliative care consulting service on a really sick patient that you took care of, what degree of alignment maybe there was between the teams, how the interactions with the family went, and then sort of what the outcomes of the patients were as well. Palliative care, specifically in kids, is known to enhance quality of life, decrease suffering, and facilitate really important goals of care conversations. And in the adult space, surgical palliative care has become slightly more commonplace, but in kids, the diagnoses that prompt palliative care consultation are very different and are mostly comprised of genetic and congenital conditions, as well as the complex sort of chronic conditions. And I don't need to tell you all that those constitute also a pretty sizable proportion of the patients that surgeons take care of. So given that surgeons play a role in treating these populations, we wanted to see, first of all, whether there was a lot of overlap. And in a study we did before this one, we found that of a group of children who were already receiving palliative care, 81% of them had at least one surgical intervention, and half of them had at least 4. And thinking about what kinds of interventions those were, they weren't just G-tubes or chest tubes or lines. A sizable proportion of them included operations that were done with the intent of cure or resection or even rescue. And so because palliative care is important for seriously ill children and because these populations overlap a lot with surgical patients, we wanted to know how palliative care clinicians and pediatric surgeons take care of them and think about these patients. So we did a cross-sectional survey of attendings that were members of APSA and then the APSA equivalent in hospice and palliative medicine, specifically who care for children. Well, we found there were some differences between our population in that pediatric surgeons, on average, had about 10 more years of experience and were more likely to be male, but want to point out that 70% of the pediatric surgeons who responded did have a subspecialty palliative care service just for children at their institutions. So 85% of everyone said that palliative care consultation was really helpful. But only half of that group actually involved palliative care in very sick children with surgical disease. By contrast, only 15% of palliative care clinicians said that they were consulted by pediatric surgeons in these same kinds of scenarios. When we asked about the timing of consultation and when palliative care was involved, palliative care clinicians were much more likely to say that that consultation occurred too late compared to pediatric surgeons. And looking at that specifically and what context those were, we asked about a variety of kinds of conditions, and what we found were that those differences were most pronounced in life-threatening conditions where cure was possible. In those kinds of diseases, what we found was that palliative care clinicians thought that the time of diagnosis was an appropriate time to become involved, whereas pediatric surgeons said that clinical deterioration was the best time to be involved. We asked a hypothetical scenario about a patient with esophageal atresia who also had a severe neurologic impairment, and whether there would be a recommendation for operative intervention if this were to cure the tracheoesophageal fistula. And surgeons were much more likely to say, yes, it should be fixed than palliative care clinicians were. But what's important to point out here is that once we specified the family's goals, whether that was desiring repair or not desiring repair, there was much more alignment between palliative care clinicians and pediatric surgeons, in that those both groups were likely to say basically whatever the family preferred. There was a lot of agreement that palliative care is not just for the end of life, that it's not mutually exclusive with invasive surgical interventions, including very invasive operations, and that it is not only for actively dying children. But the barriers to involvement were primarily around the perception on behalf of parents, that wouldn't be acceptable to parents, or that parents would perceive that there was no further incentive for curative treatment. And when we asked where there might be gaps for enhancement of palliative care education, we found that that was largely around communication and around managing parental distress. So we think that those two things can be explained primarily by the fact that more severe illness or sort of an acute deterioration seems to prompt prompt surgeons to think about the value of palliative care, whereas when the disease is not deteriorated yet or where the patient is more stable, it doesn't seem as relevant. And the other piece that we thought was sort of related to that is that there's a sort of undertone in surgical culture that palliative care and curative therapies are sequential rather than parallel elements of care, and that parents may also share that perception. What we know to be true is that parents actually don't feel that way, that they find value in concurrent palliative care, and that the outcomes, including mortality and healthcare utilization, are improved when palliative care is delivered early and concurrently with curative treatment. So there is some alignment between these two groups on the value of palliative care. There's some differences in opinion about when to engage palliative care, which may be due to surgical culture and parental perception. But one big takeaway is that alignment is improved when the parents' and families' goals of care are clarified. And some future directions are to look at how in surgical patients there are changes in their outcomes and experiences when palliative care is engaged. And then most importantly, I think, rather than trying to enhance subspecialty palliative care involvement, educating surgeons on those gaps that they express primarily around communication and parental distress management, and providing primary palliative care by surgeons themselves. Thank you.
Our last presentation is adverse events rates and resource utilization associated with different methods of laparoscopic appendectomy in children with uncomplicated appendicitis, presented by Dr. Shannon Cram.
Good morning. I have nothing to disclose. Appendicitis is the most common abdominal surgical emergency of childhood and accounts for the greatest relative burden of surgical site infections and healthcare expenditures of any pediatric surgical disease. Understanding how the different methods of appendectomy affect clinical outcomes and resource utilization may help to optimize the value of management of this common condition. The objective of this study was to evaluate the association between the different methods of laparoscopic appendectomy with adverse events and resource utilization in children with appendicitis. To accomplish this, We obtained NSQIP pediatric data from 15 hospitals participating in the Eastern Pediatric Surgery Network. These data were augmented via supplemental chart review for the operative report text. For the cost analysis, the EPSN data were merged with Pediatric Health Information System data using a previously validated probabilistic matching algorithm for the subset of 8 EPSN hospitals that participated in FIS. Children ages 3 to 17 who underwent laparoscopic appendectomy over a 5-year study period for uncomplicated appendicitis were included. Method of appendectomy was established using the operative report text. Using iterative manual review of 600 operative reports, we created an automated keyword algorithm to identify the 4 most common methods of laparoscopic appendectomy: use of a stapler, endoloop, Hem-o-lok, or tie ligation via exteriorization. As the most common method of appendectomy, stapler use was compared to the other methods, both in aggregate and individually. Our outcomes included 30-day postoperative rates of reoperation and surgical site infections, as well as total standardized operating room costs, which included time-based costs and supply costs, and operative duration. We used mixed effects regression to compare these outcomes across the various methods of appendectomy after adjusting for patient characteristics, use of advanced energy devices, and hospital-level clustering. 5,592 children with uncomplicated appendicitis from 15 centers were included. Stapler use was the most common method of appendectomy, accounting for 76% of cases, and Hem-o-lok use was the least common, accounting for only 4%. Methods of appendectomy varied widely across hospitals, with stapler use ranging from 8 to 100%, while other methods ranged from 0 to 82%. The reoperation rate overall in the cohort was 0.7%, and the surgical site infection rate was 2.2%. After adjustment, the various methods of appendectomy were not associated with reoperation rates or surgical site infections when compared individually. However, when aggregated, stapler use was associated with a 3.1 times the increase in the odds of reoperation compared to non-stapler methods. There remained no difference in the surgical site infection risk between methods. A total of 2,426 children at 8 centers were included in the analysis of standardized total operating room cost. The mean total operating room cost was $2,848, and the mean operative duration was 42.9 minutes. The results of the standardized cost analysis by method of appendectomy are presented in this slide. Stapler use was the most expensive method of appendectomy, associated with a 33% increase in the mean standardized operating room cost when compared to non-stapler methods in aggregate, which corresponded to an increase in the mean OR cost by $547 to $967 per case across the methods. The results of operative duration analysis by method of appendectomy are presented here. Exteriorization with tie ligation was associated with the shortest operative duration, a 13% decrease in the mean operative duration when compared to stapler use, which corresponded to a 5.7 to 6.6 minute decrease in the mean operative duration across methods. These data must be viewed within the context of our limitations. This was a retrospective analysis and therefore subject to misclassification of exposures or outcomes. Despite our relatively large sample size, the adverse event rate was low, and so we may be underpowered to detect significant differences. However, the adverse event rate was low across all methods of appendectomy. Lastly, these results may not be generalizable outside of the Eastern Pediatric Surgery Network. Despite these limitations, these data demonstrate the relative safety of all methods of laparoscopic appendectomy, given the very low rate of adverse event rates. When considering optimization of care and value, stapler use was the most costly method of appendectomy and may be associated with a modest increase in reoperation risk. Tie ligation via exteriorization was associated with the shortest operative duration and lower operative costs compared to stapler use. I'd like to thank my mentor, our team at Boston Children's Hospital, and our collaborators at the EPSN. I'd be happy to take any questions.
Hi, Ravi Radhakrishnan from Galveston. Nice paper. Congratulate you on the work. I did have one question. What were the reoperations that you did that you saw in the stapler group? Were they post-op bowel obstructions, something like that? And then the second one was, I would caution you on saying that staplers, are cheaper or more expensive or things like that, because it really depends on the contract your hospital has. So for instance, in my hospital, one staple load, a white load Ethicon stapler, is actually cheaper than 3 Endoloops. But it just depends on your hospital. So I'm curious, were you able to parse out some of that? Because every hospital system has different contracts with these vendors.
Yeah, thank you for these questions. So the reoperation rate was obtained from NSQIP, and so it's 30-day return to the OR, so it includes all cases, and that granularity was not within this data. Obviously, anecdotally, we've seen experiences where children return to the OR for early reoperation for small bowel obstructions associated with staples, but we don't have the data in this analysis to support that. From a cost standpoint, it is very difficult to compare across centers, and even using standardized cost data within the FIS hospitals, we see significant variation in how hospitals bill for various supplies, time-based things such as that. And so I think that it is certainly an important consideration, but that these data across 8 hospitals that are a standardized cost may be the most generalizable way to do a multi-center analysis.
Thank you.
Mark Wolcott, Akron, Ohio. I was going to ask about the reoperations as well, but I also had another question, and that is, how are you going to do your appendectomies moving forward? And I'm curious how Sean's doing his now.
I think that that is a great question. I think that the first and most important thing from these data is that all methods are safe, and so I think the answer is to do the thing that you feel is safest and you feel most confident with. Given that Thai ligation via exteriorization was fast, was safe, didn't have increased rate of infections, I think that if that's technically feasible and within my access range, then that may be a go-to method, but I certainly am not afraid of using a stapler in the future.
Tori Meyer from Austin, Texas. Could it be that we use the stapler when it's a little bit harder, and we use the ties and Hem-o-loks and the other things when it's real easy, and that explains what's going on here?
Yeah, that's an excellent question, and it's super important to consider in a retrospective analysis. So we attempted to limit confounding by indication in several ways. The first was that we limited the cohort to only uncomplicated cases that had no mention of complicated findings or advanced findings such as gangrene, suppuration, or significant exudate. And the second piece is that we also adjusted for the concurrent use of advanced energy devices like a harmonic or a ligature, which may also be associated with a more difficult case. Is there still some component that's left behind? Perhaps, but the fact that 3 out of 4 cases used a stapler, I think that there's probably some power in those numbers, that those are representative of the swath of appendectomies overall.
Mike Chen from Birmingham. One of the costs of these operations is also standardizing the cases. And do you know if all these organizations at each of the hospital, all the surgeons do it the same way? Or do they all do it, everybody has their own way, they got to have their own instruments and so forth? It's an appendectomy, right? I mean, you need a knife and a fork. That's all you need.
And maybe a stapler. That's a great question. I don't have that data, but I can tell you for a fact that no one does it the same. There's a lot of variation in how these hospitals manage children with appendicitis, both in and out of the operating room. Anytime we've looked at any measure of variation, it exists. So I'm sure that there's not a standardization across the 15 centers.
So we'll take one more question from the audience and then one from the chat.
Oliver Soldas, Dayton Children's. So I do my stapled appendectomies with a single firing of the stapler, and I know many people do 2 firings. And were you able to ferret that out? Because it decreases the cost dramatically to use a single load.
Yeah, that's an excellent question, and not something that we dove into with this data, but we hope to with subsequent analyses to look at exactly how the mesoappendix was taken and whether there were 2 staple fires used or whether there was other methods applied.
And we have one question from the chat.
Yeah, well, thank you. This is actually a question and a comment about the palliative care topic. And I see Dr. Ellis is here.
Yeah, I will defer to my colleague.
Am I good to go ahead?
Yeah, go ahead.
The comment was, thank you for this important work and emphasizing the importance of the surgeon presence in the goals of care discussions for pediatric surgery patients. The question is wondering if your survey asked about the term palliative care, since the family and medical team can have a bias about what that term means, while they may embrace what the actual provision of care would involve, such as pain control with a variety of techniques and not just medications, goals of care, quality of life, etc.
Thanks for that question. So we did not define either the term palliative care for everyone, nor the kind of, nor do we provide specific context for the clinical scenarios. What does life-limiting mean? What does life-altering mean? And part of the reason for that is because everyone is sort of speaking a different language. We wanted people to use whatever scenarios they sort of conjure up in their experiences, because that's the place from which they're going to be operating. And so we intentionally didn't do that, but in the future, one of the things that we're going to be working on is creating some standardized language so that everyone's sort of talking about the same thing.